The disease entities which can cause restrictive cardiomyopathy is quite long. Many of those are very rare, and many of those usually don't cause a severe form of restrictive cardiomyopathy. So I would like to focus on those which I think are important.
Amyloidosis is a systemic disease which is characterized by amyloid deposits in tissues of the body, including the heart. It can be caused by various different disorders, or there are various different types of amyloidosis, such as the immunoglobulin amyloidosis, which involves the light chains. This type is caused by primary amyloidosis, multiple myeloma, or B-cell lymphoma. We then have the familial amyloidosis, which is a hereditary disease, which is caused by an autosomal dominant mutation. The senile systemic amyloidosis, which is common in patients over 80 years. Over a quarter of patients over 80 have at least some form of senile systemic amyloidosis. It involves the natural transthyretin, and it also involves the atria and the conducting system of the heart. We then have the secondary amyloidosis, which is a consequence of systemic inflammation, for example by tuberculosis, rheumatoid arthritis, inflammatory bowel syndromes, or chronic infection. Cardiac involvement is most commonly present in patients who have immunoglobulin type amyloidosis. In these patients, approximately 50% are involved, and a quarter of these patients have some form of symptoms, usually congestive heart failure. The presentation in echo is sometimes very typical, and sometimes it's the echocardiogram which leads to the diagnosis of amyloidosis. What you see, and what is nicely shown in this example, is you have a very echogenic type of myocardium, the so-called ground glass pattern, and very often left ventricular hypertrophy in the absence of hypertensive heart disease. Because it's a restrictive form of cardiomyopathy, we have biatrial enlargement, and we also have thickened intraatrial septums, thickened valves, usually with mild to moderate regurgitation. Here's an example of mitral regurgitation, but we often see tricuspid regurgitation and aortic regurgitation as well. And in addition, what we often see are pericardial effusions and pleural effusions. Usually pericardial and pleural effusions mark a more advanced stage of the disease and seem to be associated with a poorer prognosis. In general, patients with amyloidosis have very good image quality simply because they have such an echogenic myocardium and because of the pericardial effusion. So you will see these patients very often also at various presentations or in covers of textbooks. In addition to the typical 2D findings, you will find Doppler features of restrictive cardiomyopathy, of diastolic dysfunction, as in this example where we have a restrictive filling pattern with a very high E wave and a very small A wave. Now let's turn to the hypereosinophilia endomyocardial fibrosis type of restrictive cardiomyopathy. Basically, it's a leukoproliferative disorder which is caused by excessive amounts of eosinophilic cells, which infiltrate into the tissue and thereby cause myocardial and endocardial dysfunction. In general, we can differentiate two different types or groups of causes for hypereosinophilia and thereby restrictive cardiomyopathy. The so-called endomyocardial fibrosis type, which is more common in Africa since it's related to parasitic disease, and the hypereosinophilic syndrome, which is a heterogeneous different group of causes which also causes hypereosinophilia and thereby restrictive cardiomyopathy. There are many different myeloproliferative variants of HES, as you can see here on the list. It can also be associated with the Church-Strauss syndrome, for example, and we have seen several families where HES is present.
This is a patient with endomyocardial fibrosis, and I will now show you the typical features that we can find in such patients. In the peristernal long axis view, we can appreciate that there is fibrosis of the subvalvular apparatus. which extends here into the papillary muscle and also into the posterior mitral valve leaflet. You can see that the posterior leaflet is restricted in its motion, and we can expect at least some degree of mitral regurgitation in this patient. But the real interesting or real typical findings for endomyocardial fibrosis are usually seen in the apical views. Let's take a look at the apex. You see the image quality is not very good, which is easily explained because we have fibrosis and also an infiltrate here in the apex, so that we don't get very good image quality down here, but we can nicely see that there actually is an infiltrate here in the apex, very equilucent structures which fill the apex and which are very unlikely to be a thrombus simply because we have a normal contraction pattern here in the apex.
So this is actually the same patient you just saw only 3 years earlier. You can see that the patient at that time, he had even more infiltrates in the apex. They're just not as echogenic as they are in the demonstration. And the patient received monoclonal antibody treatment after that and responded quite nicely also with respect to his eosinophils. How can we differentiate this from a thrombus? Well, simply because we have hypercontractile function. It would be very unlikely to have a thrombus in such a region. Again, take a look at the fibrous thickening of the endocardium. Endomyocardial fibrosis, that's the name of the disease. And remember that the infiltrates can be located not only in the left ventricular apex, but also in the right ventricular apex. Now I want to go to our patient and show you his diastolic function.
In patients with endomyocardial fibrosis, we often have myocardial involvement. So we do see both diastolic and systolic dysfunction. Let's look at the diastolic function of this patient with endomyocardial fibrosis. First, we will have to look at the Doppler spectrum across the mitral valve, which is not easy in this patient simply because he has shadowing of the mitral valve due to the infiltrates that you see up here. So I will show you the pre-recorded Doppler spectrum. And what we see is an E wave which is taller than the A wave. And the question now arises, is this normal function or does the patient have pseudonormal function? To further elucidate that, we will then perform a tissue Doppler spectrum across the mitral annulus and measure the maximal E prime velocity, which is 0.07. And if we look at the ratio, we get a value of 13, which would mean that the patient has elevated left atrial filling pressure. So, in summary, this cannot be normal diastolic function, but it has to be pseudonormal diastolic function with mildly or moderately elevated left atrial filling pressure.
So as you saw in this patient, and as I mentioned earlier in the presentation, patients with restrictive cardiomyopathy do not necessarily have to have a restrictive filling pattern. This patient only had pseudonormal pattern. So there are different stages which also are described as a necrotic stage, a thrombotic stage, and a fibrotic stage. And we know that a restrictive filling pattern is way at the end of the line of the disease. It's a late stage sign. Since fibrosis also involves the endocardium of the valves, you can expect to also find regurgitation in many patients. Sometimes regurgitation can be very severe. Usually in these cases you find a restrictive motion of the leaflets. Our next form of restrictive cardiomyopathy is sarcoidosis. Sarcoidosis is a granulomatous disorder of unknown etiology. It's a systemic disease which primarily affects the lungs and which is present or which occurs also and primarily in young adults. Cardiac involvement in sarcoidosis has been reported to be somewhere between 20 and 30%. In most of these cases, cardiac involvement is silent, and echocardiography is quite poor in actually making the diagnosis of cardiac sarcoidosis. Magnetic resonance imaging seems to be superior. Once cardiac involvement or sarcoid heart disease is present, patients have a very poor prognosis. Once the first symptoms of cardiac involvement appear, the 1 to 2 year mortality is approximately 65% only. In addition, approximately 80% of patients who have sarcoidosis die because of cardiac involvement or cardiac problems, usually sudden death. So what are the typical features that you can find with echocardiography? Primarily regional wall motion abnormalities, left ventricular aneurysms, and pericardial effusion, as in this case here. Here again we have an example of a patient with regional wall motion abnormalities which often don't follow the typical pattern of coronary artery disease. Very echogenic myocardium, which seems to denote some form of edema. Edema might also be an indication for a more active disease process, and echogenic myocardium caused by fibrosis. Example of a patient in the end stage of sarcoid heart disease. You can see the patient has severely reduced left ventricular function with a very thin septum, very similar to a patient who also has dilated cardiomyopathy, some degree of mitral regurgitation and also aortic regurgitation. The patient also has a pacemaker because of conduction abnormalities and significant tricuspid regurgitation with pulmonary hypertension. So in the end stages, a very severe disease, and this patient actually died only shortly after this echocardiogram. The last form of restrictive cardiomyopathy I would like to show you is morbus Fabry. It's a very rare disease, but there is a specific treatment for this disease. It's an X-linked genetic disease which causes or results in an alpha-galactosidase deficiency. It is associated with angiokeratomas. This is such an example. And the patients usually suffer from renal disease. The echocardiographic findings in morbus Fabry are quite unspectacular. The key feature is left ventricular hypertrophy. Again, in the absence of hypertension. Note that we also find a restrictive filling pattern, especially in advanced forms. Remember, we're talking about restrictive cardiomyopathy. And what we sometimes see is we see abnormal strain and strain rate patterns.
So finally, I hope after this lecture you will not find it so difficult to make the diagnosis of restrictive cardiomyopathy. Of course, we cannot perform histology. We can only suspect that there is a problem. We need other tests to confirm it. One thing which I find very important, if you have a patient who has signs of right heart failure, you always also have to exclude restrictive cardiomyopathy. Keep that in mind, and you will make the diagnosis more frequently than you probably thought you would.